Good afternoon. Let's start with a simple thought experiment. When you hear the word patient, what comes to your mind? Almost certainly one person. Someone in a bed, someone across a clinic desk, someone whose chart you're recording vitals on. That's the image a clinical medicine has trained into us. Today, I want you to stretch that image. What if the patient isn't one person, but an entire village, an entire district? What would it mean to take that community's vitals, reach a diagnosis, and prescribe the treatment, not for one body, but for a whole population? That is population medicine, also called community medicine, the same name as this subject. By the end of today, you will be able to define it, see exactly how it differs from the clinical medicine you already know, understand the tools it uses, and know three of its foundational ideas: the iceberg of disease, community diagnosis, and the population versus high risk debate. This is drawn throughout from Park's textbook of preventive and social medicine. So keep the textbook nearby for extra detail. Let's make this precise. Population medicine is the branch of medicine concerned with the health of populations and communities as a whole, rather than the individual patient. The operative shift here is the last few words, as a whole. In other words, what is wrong with this patient? Population medicine asks a different question from the clinical medicine. What is wrong with this community and who in it is at risk? Notice that population medicine's question already has two parts. It is not only about the disease that is already present, but also about who is vulnerable to disease in future. That is a more forward-looking stance than clinical medicine usually takes. In population medicine, the unit of care becomes the whole population. Its health is measured, its problems are diagnosed, and care is planned for the group, not the individual. Hold on to that phrase, unit of care. We will return to it constantly. Clinical versus population medicine. Let's put the two side by side, feature by feature, because the contrast sharpens both. Unit of care, the individual patient versus the community or population. The main aim is to diagnose and treat the illness versus assess the needs, prevent and promote. Okay, I hope you are understanding. I've already taught this during the class hours. I explained it to you very clearly. Go through your class notes also. Keep the Park and Medicine book next to you along with the lecture notes which I have given it to you in the class also, so that it will be easy for you to understand as I am explaining now. The next one is usual setting. Hospital and clinic versus homes. The field and the community itself, which is exactly why community health takes you out of the ward and into people's home. In case of clinical medicine, the main tool is clinical exam and investigations, whereas in the community medicine, it is epidemiology, surveys and statistics. And in case of clinical medicine, the emphasis is more on curative, whereas in case of population medicine or in case of community medicine, it is basically preventive and promotive. Now, can you see in the slide, the last row? I want you to sit with this one, okay? The denominator. Clinical medicine doesn't usually need one. You are not calculating a rate for a single patient. Population medicine cannot work without one. We don't just count cases. We relate those cases to the population at risk and we work in rates. Why does it matter so much? 10 new cases of a disease sounds alarming in isolation. But 10 cases in a community of 500 tells a very different story from 10 cases in community of 50,000. Without a denominator, you can't compare one community to another, and you can't tell if a problem is getting better or worse over time. The denominator is what turns a head count into a measurement. Park uses several terms that sound almost interchangeable: public health, preventive medicine, social medicine, community health. Okay, so let's untangle them. You have to know the distinguished factors between this one. Okay, public health, if you look at it here in the slide, is the science and art of preventing disease, prolonging life, and promoting health through the organized efforts of society. Can you look at the word organized? So this is society acting collectively, not one clinician acting alone. Preventive medicine applies preventive measures to individuals and groups to keep them healthy. So it can operate at the individual level too. Social medicine actually can be defined as, if you look in the slide, we have given you very clearly what it means by it. Population medicine has 6 linked objectives, and they aren't a random list. They run in a cycle. Okay, you can see it in the slide. I think the cycle will be very familiar to you all. It should. Assess, identify the problem, plan, act, evaluate. It is simply scaled up from one patient to an entire population. It's not a new brand way of thinking today. You are just learning to apply a way of thinking you already have to much bigger patient. If you look at assess the community, it measures the health status and needs of the population. Find the problems means identify the health problems, priorities, and the groups most at risk. Plan the response means plan, implement, and evaluate the health programs and services. Prevent and promote is actually preventing the disease and promote health across the population. Ensure equity, that is, deliver fair, accessible care in pursuit of the goal you will hear repeated throughout this subject. Okay, health for all. And study and watch, carry out research and ongoing surveillance of the community continuously and not just once. Let's bring this full circle. Okay, recall the individual clinical processes. Once a patient comes for treatment, how will you go about it? Here is a parallel to carry through the rest of this subject. Examine the patient, diagnose, treat becomes study the population, community diagnosis, community treatment, evaluate. Okay, so same logical structure, entirely different scale.